Dear Professor McGinty, dear Professor Naguib, dear friends, it is such a pleasure to participate in the ICR Egypt 2023 Congress. I am so very sorry that I'm not able to be there with you in person. Please accept my sincere apology. It is an honor, and I very much appreciate the opportunity to share with you the overview and recommendations of the Lancet Commission on Imaging and Nuclear Medicine. Before I start my presentation, allow me to show my disclosures. I serve on the Board of Directors, IBA, Board of Directors, Page AI, on the External Advisory Board for the Johns Hopkins Cancer Center, International Advisory Board, University of Vienna, both on Scientific Committee and Board of Trustees for HEDVIG, and I also serve on the Scientific Advisory Board, Eurobioimaging. Today, we say that cancer is a global pandemic. By the numbers, in 2000, we had 10 million cases of cancer. Then, at that time, the prediction was that in 20 years, we will have 15 million. Wrong. In 20 years, global cancer increased for more than 50%, and the number is 19.3 million. Now, for the next 20 years, the prediction is that we'll have another 47% increase. Remains to be seen, but what we see right now, once again, the numbers will be larger. Another thing to remember, that cancer as a leading cause of premature death is really worrisome. In many countries, including the United States, Argentina, for example, Western Europe, China, as well Australia, cancer is in young age 30 to 70, is a #1 cause of mortality, followed by cardiovascular disease. We are in Africa, Northern Africa, and in Northern Africa, including Egypt and the adjacent country, cardiovascular disease is the #1 problem, followed by cancer. When we look at the global incidence for female, the world is really pink. It's very pink for incidence, but when we look at the mortality, then the colors change. In many countries, including Canada, United States, Australia, lung cancer is the #1 cause of mortality. When we look at Northern Africa, then in Egypt, the #1 cause of mortality is still liver cancer. Followed, and then adjacent country, it is breast cancer. When you have a pink on the incidence and the mortality, you know that the prevention, screening, and early diagnosis need to be implemented. How about cancer in males? Incidence, by far prevalent, is prostate cancer. However, not in Northern Africa. In Northern Africa, for males, a #1 cancer, once again, is liver. And then in adjacent Libya and Algeria, the #1 cancer is actually lung. As looking at the mortality, we have, again, Algeria, Libya, lung cancer is a number one cause of mortality, as is in the majority of the world. But Egypt, as well as adjacent Sudan, liver remains number one. Knowing that the top 3 global risk factors are smoking, drinking, and obesity, and are responsible for over 40% of cancer deaths worldwide. For the region of Northern Africa, we really can put some preventive measures. Number one, smoking. In some parts of Africa, as we all know, it's truly prevalent. Drinking is not a problem, but obesity is, especially in Egypt, as the data show, more than 40% of population is obese, and obesity in Egypt is especially a problem in childhood and children. So there is much we can do without going in any advanced treatments or imaging modalities. As we look at global cancer facts and figures, we said in the next 20 years, the new cancer cases worldwide are projected to grow by 47%. As reported at the London Global Cancer Week in 2021, cancer has reached global pandemic proportion. In the low middle income country, cancer mortality is surpassing the total global mortality from HIV, AIDS, malaria, and TB combined. And unfortunately, there are dramatic worldwide inequalities in access to cancer care, and with the latest pandemic of COVID-19, the differences are growing. Disability adjusted life years lost to cancer, 80% occurs in low middle income countries. Yet, only 5% of portion of global funding for cancer control and care is applied in that region. And it has profound impact on mortality. Let's look at the survival in prostate cancer, which, as we've shown before, is one of the most common cancer in men. In the United States, 5-year survival and other high-income countries is over 98%. Color is dark green, but that is certainly not true in the remaining of the world. The world is too colorful, and the more orange or dark brown it gets, the worse the mortality. So as we look at the Northern Africa, Egypt, Sudan, adjacent Libya, or Algeria, Morocco, even that region is very different. And it's up to you and this Congress to really discuss how to make it better and more uniform for those countries that really need. Prostate cancer is a genetic disease, but there's much more to the survival and well-being of prostate cancer than genes. We can look at as we look at Oman and Yemen. The survival in Oman is actually excellent. It's around 90%. In Yemen, you have almost no chance to survival. It's below 10%. When we look at Afghanistan and Pakistan, striking difference. Continuous war impacts not only life and economy, tremendously impacts on health care and ability to survive. The same we can see in breast cancer. Survival is above 90% for Western Europe, for Australia, and again, too many different colors in North Africa. And once again, look at the difference between Oman and Yemen. Look at the difference between North and South Korea. It just shows you that continuous problems and wars truly destroy country in so many ways. Cervical cancer, it's a huge problem in Africa. We all know that. Mortality in the sub-Sahara region is unacceptable. It's below 10%. And again, we have the same story, looking at those countries that are continuously affected by war. And then we really need to ask ourselves, can we continue to witness that one's postal code and not one's genetic code determines one's survival? And this was actually the main reason behind the Lancet Oncology commissions. The first commission addressed surgery. The second was global access to radiotherapy. And they both concluded that lack of clear, overarching global strategy for scaling up cancer imaging diagnostics across low middle income countries is a huge problem. And this was the birth of our commission on Lancet Oncology on medical imaging and nuclear medicine. The commission was very well embraced by a number of societies, institutes, organizations, and foundations. I am really proud to say that we did not receive any industry support. Rather, we received the support from our peers, multidisciplinary, as not only radiology and nuclear medicine society supported, but there was a support from ASCO, from Aortic, ESMO, ASTRO, and so on. And most of all, this is the time to say thank you to IAEA. IAEA was instrumental not only in initiating this commission, but providing the data that I'm happy to share with you. So IAEA Imaging Database allow us for the first time to have global benchmarks on diagnostic imaging equipment per 1 million inhabitants. And once again, the world is too colorful. As you can see, there are more than 30 CT scans, United States, Argentina, Australia, and parts of Europe, such as Germany, Italy, Switzerland, Austria, and Norway. But even in the Western countries, the distribution of CT scanners per 1 million inhabitants is not adequate, such as United Kingdom. And then, of course, looking at the Northern Africa, there are differences, and we all know there are. And that's what the future policies on healthcare need to address. And then when we look at Oman and Yemen, it's very easy to understand that the outcome of any cancer survival will be very different. MRI scanners are very similar. Now, MRI scanners, the number of scanners in the United States, Nordic countries, again, Germany, Austria, and Switzerland, a very similar story. UK and France maybe needs to be improved. But Northern Africa, such as our own Egypt, really is very low on the distribution of MRI scanners. Actually, their distribution in Egypt is less than 2.4 scanners per 1 million inhabitants. And then PET scanners, Interesting enough, the PET scanner in Northern Africa is low but evenly distributed across the countries, and as we can see, it has less than 0.9 PET scanners per 1 million inhabitants. In big parts of Africa, there are no PET or PET-CT scanners that were recorded by IAEA imaging database. Another benchmark that for the first time we have is human resource per 1 million inhabitants. We all know that there is a lack of radiologists, but when we look at number of radiologists per 1 million inhabitants and compare different countries with United States and Western Europe, once again being our benchmark. UK, we all know, has too few radiologists. But let's look at Africa. Egypt, Libya, there was a tremendous brain drain and very few radiologists. Algeria is a little better, but still not adequate. And then there are large part of Africa that really we either didn't have any data or they have less than 0.9 radiologists per 1 million inhabitants. The picture is even worse when we look at the nuclear medicine physicians. It is really worrisome, as PET-CT is such an essential element in oncologic imaging. There are countries and countries that have less than 5 PET-CTs per nuclear medicine physicians per 1 million inhabitants. So now that we have the benchmark data, let's look at health and economic benefits of scaling up imaging and nuclear medicine, the data that every Ministry of Health or Ministry of Economy will ask for. First of all, as physicians, we are really interested in averting cancer death. So as projected, if we don't do anything, by 2030, we'll have 76 million people die from cancer. If we scale up treatment and quality on care, which was the Commission on Surgery and Radiation Treatment, we avert 5.4 million. But if we add imaging, it goes up to 9.5 million. If we scale up surgery, radiation treatment, and imaging, we have an opportunity to avert 12.5% of all cancer deaths worthwhile, and that is a large number. I want to take this moment an opportunity to really say sincere thank you to Professors Zach Ward and Rifat Atun from the Harvard School of Public Health. It was their modeling and their understanding on health economics that for the first time allowed us not only to show impact on survival, but also show us return on investment if you invest in imaging. For every dollar invested, if you scale up treatment and quality of care, the return on investment is $6.15. But if you add imaging, then the return on investment doubles. And this single slide, so far as we look at the progress that occurred with our Lancet Oncology Commission, is probably one of the most valuable part of our data. So what are our key accomplishments? First, for the first time, we have comprehensive global data on imaging and nuclear medicine, equipment and workforce, and once again, sincere thank you to IAEA Imaging Database. For the first time, we have demonstrated the substantial health benefits of scaling up imaging and nuclear medicine access for patient care globally, and then a very compelling economic case for further investment in imaging and nuclear medicine. A sincere thank you to our friends from the Harvard School of Public Health. Recommendations are numerous. One, of course, imaging diagnostics must be a part of essential benefits package when expanding universal health coverage. National cancer control plans absolutely must include actions for scale-up cancer imaging diagnostics, and that includes equipment and workforce. People are the key to our success, and the workforce development through investment in education and training is absolutely essential. At the same time, we need to foster collaborative networks and, of course, invest in R&D to foster innovation, but also to gain additional knowledge that we can share with all other global communities. There are a number of early accomplishments. Lancet Imaging and Nuclear Medicine Data Commission dissemination is done at a number of meetings and congresses outside our own radiology and nuclear medicine communities. Next, our data had a number of inclusions in industry business plans, and the progress in getting more equipment in low middle income countries has already been seen. IAEA initiatives Rays of Hope is fantastic, and in part it was facilitated by data from this commission. WHO and UICC use our data in consideration in their policies. And then two items in progress, and that is World Health Assembly resolution on diagnostics. It will be voted on in May at the Assembly meeting. And following that, probably on the floor in 2024, is our WHO resolution on imaging and image-guided therapy. If those two resolutions are accepted, we are going to ensure that imaging and image-guided therapy becomes a part of the national plan. And then another encouraging news. U.S.-Africa Leader Summit in Washington, December 2022. President Biden extended the Cancer Moonshot Initiative to Africa. Lancet Oncology was ready and immediately put together a Lancet Oncology Commission on Workforce in Africa, Latin, and South America. In the words of President Biden, recognizing that cancer has no geographic, racial, or socioeconomic boundaries, he extended Cancer Moonshot to Ending Cancer as We Know It to Africa. And our commission is going to focus on the workforce, and it's to define the scale of cancer healthcare workforce deficit and provide solutions inspired by Moonshot principle that would help deliver safe, effective, and efficient health care to enable all patients to have equitable access to care at the time of need. I am absolutely delighted to say that imaging and nuclear medicine will be presented in this new commission that addresses workforce from physicians, technologists, nurses, and so on. And hopefully, next time at the ICR meeting, we'll be able to share with you the updated data. So with this in mind, thank you very much for your attention, and hopefully at the next ECR meeting, I will be able to see you in person. Thank you.
Thank you, Dr. HRICAK. I'm going to invite our panelists to come up, and while they're coming up, I'm going to give you very brief bios on them. I could spend the entire time telling you about their many accomplishments. Dr. Boris Berklik, who is Professor of Radiology and Vice Rector at the University of Zagreb.